Youth Learning Community. At this time, I'd like to go over a couple of housekeeping items. We'd like to encourage you all to participate in today's webinar via 3 methods. First, if you have questions for the presenter or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. Periodically throughout the presentation, the presenter will stop and ask for questions, at which time I will read aloud any questions that have been submitted. Again, you can submit questions via the comment or questions box. Throughout the presentation, all participants will be on mute. If for any reason you would like to be unmuted, please click the Raise Your Hand request and unmute your personal phone or mic. I, as the organizer, will unmute you to speak directly to the presenter and group. You're also able to collapse and expand the GoToWebinar panel via the arrow button should you choose. At this time, we're going to go through 4 poll questions, and we'd like to get a picture of the demographics and SBIRT experience of the audience. These questions will appear on the screen as an interactive poll. Please select the best answer as it applies to you. Okay, thank you for all who participated in the poll. I'm going to share those results. And now for our next question. What field do you represent? Mental health, addictions, physical health, education, or EAP? Okay, I want to thank everyone for participating in that poll. I'm going to share those results. And for our third question, do you conduct SBIRT interventions? Okay, I want to thank everyone for participating in that poll. I'm going to share those results. And for our next question, do you see your agency using SBIRT? Okay, thank you to everyone for participating in that poll. And here are the results. And finally, our last question. In which settings are you most likely to implement SBIRT or assist others to implement SBIRT for youth? Okay, I want to thank everyone for completing all of the polls, and here are the results for that last question. Okay. Now, at this time, I want to take a moment to tell you about the National SBIRT Addiction Technology Transfer Center. We are SAMHSA funded by the Substance Abuse and Mental Health Services Administration, and we offer a suite of services that you can find on our website. Some of these services include our National Registry of Qualified SBIRT Trainers. You can search the registry by state to find SBIRT trainers within your region. We offer monthly live webinar series on a variety of SBIRT topics, as well as have a library of free recorded webinars that can be accessed from our website. We offer technical assistance and consultation at request. This might include general information requests or more in-depth training requests. And we're open to collaboration with various organizations and entities. Our website also hosts many online resources, such as downloadable products that are easy to use, like toolkits for practice and digital tour guides, which are 2 to 4 minute overviews of specific products. You can also sign up for the SBIRT Alert, our electronic newsletter, to receive training and webinar announcements, as well as additional SBIRT information. And lastly, the I Read a Blog, hosted through our parent organization, offers stories of SBIRT in the real world. All of these, as well as additional resources, can be found on our website. I would like to mention our free self-paced online SBIRT for Adolescents course. This course is based on a webinar presented by Dr. Sharon Levy on the application of SBIRT with adolescents, and it's hosted on our website and is approved for continuing education credits. Some of the goals of this learning community include examining the application of SBIRT in a variety of youth settings. We want to create a community of providers who have a similar interest in implementing SBIRT for youth, as well as facilitate the sharing of experiences with implementing SBIRT in youth settings. And finally, as a learning community, we encourage you to return to upcoming sessions. Our next meeting is November 24th from 1 to 2 p.m. Eastern Standard Time. We also have an online webpage that lists resources specific to SBIRT for youth and want to provide technical assistance such as support for implementation, coaching, and troubleshooting by request. You can contact us at sbirt@attcnetwork.org. Now at this time, I'd like to introduce our guest speaker for today, Geoff Miller. Geoff Miller has worked in the human services field for over 25 years, managing the delivery of services for those with mental illness, substance abuse, and developmental disabilities. His experience includes planning and developing services in the urban, rural, and rural remote areas of Washington State, and he is presently the SBIRT Program Coordinator for King County. Geoff, if you're ready, I can turn things over to you now.
Sounds wonderful, Sarah.
Okay.
Hello to everyone. It is a privilege and a pleasure to be here. So as Sarah said, my name is Geoff Miller, and I work for King County Mental Health Chemical Abuse Dependency Services Division of our Department of Community and Human Services. I've been with King County for nearly 18 years in the behavioral health field since 1990. Presently, I have been working on the WASBIRT, or Washington SBIRT, Primary Care Coordinator for King County, working with the Swedish healthcare system, where we have 3 clinics up and run, primary care clinics, and 3 more planned. The Franciscan healthcare system with 1 clinic and 2 more planned. I also work with 3 of our healthcare systems emergency departments that have implemented SBIRT, and with Sound Mental Health, one of our community mental health centers, who has implemented SBIRT. Today we're here to talk about SBIRT for youth and the model that we are in the process of implementing. So I'll flash the learning objectives up for you just real quick. So I know that as a learning collaborative, we're all familiar with these for sure. But as an overview, where are we? Well, Washington State is up at the far northwest corner of the United States. King County is right there in red. And it is the 13th most populous county in the United States with a population of approximately 2.1 million. You might be most familiar with the Seattle area. But as you can see from the map that's up now, is that we also include some large suburban areas, as well as some rural areas that
Geoff, it sounds like we just lost your audio. There, you're back on.
Oh, I'm back on. We were included in a SAMHSA SBIRT grant in 2003 to establish SBIRT in hospital emergency departments. We have continued to sustain SBIRT in 3 emergency departments with local funds since 2008. We are in the 5th year of a SAMHSA SBIRT grant to expand SBIRT into primary care settings. We have used local funds to support services that include screening in several of our middle schools since 2008. We were selected to participate in one of the Reclaiming Futures juvenile justice sites supported by Conrad and Hilton Grant, beginning in January of 2015. And this journey really begins with crafting the 5-page response to Reclaiming Futures request for proposals and mulling over some data and facts that we know. Reclaiming Futures is a marvelous organization, but I really must give credit to this man, Evan Elkin. Not only do I admire the organization, the work we've been doing with them since I think 2001 here in King County in our juvenile justice system, but Evan has been the creator of the extended brief intervention that we're using with our youth in our schools now. So Evan is, of course, a nationally respected innovator and leader in the field of juvenile justice, child welfare reform, mental health, and substance abuse treatment and youth development. Originally trained as a psychologist in New York, at New York University, and a researcher at the New York Psychiatric Institute and Columbia University's Department of Child Psychiatry. His work really has been a key to our movement into the youth SBIRT field, and we'll talk just a little bit more about that in just a moment. But I wanted to show you this particular pyramid. Many of you who have been working with SBIRT are familiar with the alcohol pyramid that's in use. This one was put together for us by Chestnut Health Systems out of Bloomington, Normal, Illinois. What they did was took the substance disorder screener from the GAIN SS, their short screen instrument, and used national data to populate it for particular age groups. King County really is not a great deal different than this national picture here, and we see that from some of the surveys that we do with our youth on an annual basis. Our Healthy Youth Survey, for instance, is done annually with 6th, 8th, 10th, and 12th graders, so we get a picture of things over time. So what we also know within King County is that the age of first use is 13.1 years. That's based on individuals or youth that have been assessed for treatment. We've got approximately 12,000 assessments since 2004 that we have done using the Global Appraisal of Individual Needs. So I'm pretty confident in our data, and I've actually been watching it go down from slightly above 14 now to just above 13 years of age for age of first use. When we look at the next age group, the 18 to 25-year-olds, we find that King County is similar to this pyramid as well, where we see a tripling of those with a high need for a substance use treatment and are having a significant number of symptoms. We see the moderate level expand from 9% of our youth 12 to 17 to almost 4 times that for our transition age youth. And that's a scary set of pyramids. So our first question was, where and when do we intervene with a prevention model, in this case SBIRT, to do the most good? Should we do that at the initial juvenile justice involvement or before? Well, our answer was in the literature and in Washington state law. For us, it's called the Becca bill. And it was offered as a positive potential by our colleagues who work with truancy petitions and other aspects of the Becca bill or this particular law. The literature itself was very compelling. And as we got further into the literature, we note that truancy appears to be a robust predictor of substance use, as well as juvenile justice involvement and a number of other problems. But our next question was, is it workable? How large a population of youth are we talking about in King County? So here are the truancy stats from the 2012-2013 school year that are put together by our Superintendent of Public Instruction. We have an enrollment of K through 12 of about 250,000 youth. We have students with unexcused absences during this year, about 77,000. Students with 10 or more unexcused absences, over 12,000. But truancy petitions that were filed, and all of the youth that have 10 or more unexcused absences in the year certainly could have been filed, but we filed about 10%. So just a note of caution and support for our schools. They are underfunded, understaffed, and underfunded for reimbursement for the time to file and make contacts for a petition. You know, OSPI has given us a number of reasons why, but that still doesn't erase the fact that we have a large need that has been unmet, and that we've got the potential of using truancy as a marker in which to start the process of intervening. But we also wanted to take a look at it. Was this just a single year, or has there been a change over time? If we look at 2010 through 2014 and the number of petitions filed, we see that we've got a downward trend line. And we're also not seeing really any other interventions showing up for assistance for these truancy cases. So our next question was, what should we do? And so we came up with SBIRT, and to be honest with you, this is the modified version. The original one was just pointing to referral to assessment or to a brief intervention. So what this shows is really your first look at the brief or extended brief intervention that we're going to be using in the 4-session component that Reclaiming Futures has put together. What it actually looks like when we look at it in structure, this particular flowchart might show a little bit more detail that we're working with in order to try to capture the youth in the pre-screen or the behavioral pre-screen. We want to work with our middle schools, especially late 6th grade, 7th grade, and 8th grades, to use unexcused absences, especially at the second absence as a behavioral pre-screen, to make the referral to a full screen, and those screening as in need of further interventions, we want to move them towards or motivate them towards accepting a brief intervention, or in our case, the extended brief interventions that I'll talk about in just a moment. At this point, do we have any questions?
Geoff, we don't have any questions in the questions box, but I do have 2 hands raised. Mm-hmm. And I'm going to apologize to the audience if I mispronounce anyone's name. But Kalila Smith, I'm going to unmute you if you'd like to voice your question. Okay. Again, I apologize for mispronunciations. Rumfield Lori, I'm going to unmute you if you'd like to voice your question. Okay. Sometimes I think people hit the hands raised by accident, so we'll just keep moving forward. I have one more here. Oh, and they've just put their hand down. So if anyone has any things that they'd like to ask live on the webinar, feel free to use the raise your hand option and we will unmute you. If you don't want to speak onto the webinar, you can submit questions to the questions box or the chat panel and we will address them to the group. Okay, Geoff, I'll give it back to you.
Great, thank you, Sarah. So our pre-screening, we also recognize that since we were intervening early at a time possibly before the first use of alcohol or drugs, we would need to expand our screen and the nature of the brief interventions to address the underlying issues that can cause someone to want to feel good or feel better, which a wise man once said are the only 2 reasons anyone uses alcohol or drugs. So our next question was around implementation. Was who would we use, and there was not sufficient grant funds for a program or a separate program in the schools. But we had an idea of using existing staff, and we knew that the risk behaviors that we were dealing with would certainly be there when we started screening. So the treatment agencies and schools that we were already working within look like this, with the addition of Sound Mental Health and those particular 5 middle schools. So we've got a presence in each of those schools for at least a portion of the week already. Their mandate was to be there for prevention and intervention activities, but most of the individuals who are in the schools are clinicians. So they do have the clinical background to be able to handle an extended brief interventions or to be able to deal with the problems that come up. And actually this list is now a little on the short side. We're in the process of working with some additional middle schools and at least one high school, not all of which will be part of the Reclaiming Futures group, but it is our goal to look at truancy and the intervention with sufficient numbers to be able to establish that it is a good way for us to work with youth in the schools. We started off with the Seattle schools, and those are the 5 down in the pink down here. And we began working with the truancy interventionists that were actually being funded by a grant through the Seattle School District. And we had a chance to work with them for about 3 months to really kind of hone what we were doing with the middle schools and to understand how the schools were working with truancy and the issues that had. We also chose these schools along with, especially with the help of the Seattle School District, because these are the 5 schools that actually feed the high school that has got the highest dropout rate. So, perfect, we had a start. But the grant was ending in June, and there was not going to be an extension, which we found out late. So although we trained and learned a great deal from the folks working with youth in these schools, and learned a great deal about unexcused absences in school process, we lost them all at that point. And so now we're moved back to Sound Mental Health helping us out with staff that they already had working in those schools for mental health purposes, as well as, I believe, care management. So one anecdote that we did learn from this group is that this year's 4s and 5s, those students with 4 or 5 unexcused absences, were the next year's 8s and 12s. So we could see that those that were coming up as having 4 to 5 absences in 6th or 7th grade, by the time they reached the next school year, were actually did not have their problems addressed and were leaving school in larger numbers and more frequently. But we did have a plan B, and I would always recommend a plan B. One of our county-funded programs, which is funded by local tax dollars, has clinical staff in the middle schools, which is where this list that's up on the screen comes from. It was funded through calendar year 2016. It's also up for renewal. All we had to do was to refocus on the nature of the interventions that they were using and bring the screening tool and the Reclaiming Futures brief intervention, and we were able to move forward. So the screening tool that we adopted is the GAIN SS, or the GAIN short screen. But one of the brilliant things that Evan did was he said we really need to have a motivational interviewing bent spirit for this particular intervention, and he put together 6 questions that are really the very beginning of our screening process. What are things that you like to do for fun? What are you good at? The positive side, an opportunity for engagement and an opportunity to get to know the youth, and to also build on some things that you really want to help the youth do as they contemplate change. And one of those is, what do you want to be doing in a year and 3 years? So that seemed like that was going to be workable. So these are some of the questions for the GAIN SS. If you're not familiar with that, Chestnut Health Systems or just searching on the GAIN short screen will get you a tremendous amount of information on the use of it. There are 23 questions. There are 4 individual screeners which stand alone, which have got a very high sensitivity and specificity. And we've been using it for a number of years and actually have begun using it with these particular middle schools in this last year. So they were already familiar with the tool. And the other nice thing is that we do have an assessment building system that will actually work, will collate the data, and it's got the capability of providing some feedback reports. So the final version will end up being more seamless in terms of what we're going to be using beginning in January. It will include those 6 questions that we looked at in just a moment ago. Oops. Well, those 6 questions, plus a little bit of a modified version of the GAIN SS. We are going to be not using the crime violence scale for the Reclaiming Futures project. And then we'll also produce a personal feedback report that's geared around motivational interviewing. So the modifications will actually be electronic and in our data system. So just a reminder, the extended brief intervention is that semi-structured conversation with the youth that is about an hour in length and may actually span into, for us, with this particular model, would be up to 4 sessions of about an hour in duration. An hour duration each. But let me talk a little bit about this particular model, this brief intervention sequence. In the youth session number 1, it's where you're establishing an engagement with those 6 questions, and you're doing the screening, and you're getting the youth prepared for session number 2. Session number 2 is actually doing some planning with the youth, and the last 2 sessions could be a session with the caregiver or guardian or parent as a one-on-one, and then the last session could be a session with the youth and the caregiver together. Now, each of these have been structured out, and I'll talk a little bit about those. But before I do, are there any questions, Sarah?
Hi, Geoff. We just had one question come in.
Mm-hmm.
Are there any schools and programs in Houston, Texas that I can use the program for youth in my community?
I'm not familiar with the Houston area, so I really can't answer that. But we are looking at this particular intervention being done in with 5 nodes across the country. See if I can remember them all. New York, Vermont, North Carolina, and Ohio, as well as here in Washington State, and Oregon. I can't forget Hillsboro, Oregon. So it's starting to come into its own in terms of this particular intervention. But would encourage you to look it over closely and then look at what your implementation sequence would be within the Houston area.
Okay, I have another question here for you. Do you know what's possibly being done in North Carolina?
Not specifically.
And we can try to provide some of that information as well after the webinar. We can look some of that up for you all.
Yeah, I'm afraid my focus has been on my little piece of the world.
And then here's the last question. How long of a period of time between sessions is recommended?
We're still working through that period of time that's recommended, but you might want to take a look at this as being several days between each session. So this is not going to be a real fast sequence, but it's going to be a sequence that allows the youth to basically take the information in and then come back for the second session.
Okay, great. If anyone else has any additional questions, please feel free to submit them to the questions box, and we'll address them at the next questions period.
So the session number 2 is really, the goal is to make an action plan. So it's structured that way. And of course, we really have to get around that distance, which even if it's a couple hours, may actually take some re-engagement to get past the yeah, whatever that we might get from the youth. But the goal is setting goals and making plans, and preparing for the optional sessions of the sessions 3 and 4, the session with the parent, the session with the youth and parent. One of the tools that we use is this sheet, which it's still being worked through, but this is pretty close. And this is a Planning for Change worksheet to work with the youth to actually get them to select a goal or a change target once you've got the motivational interview and you've got some change talk going, but also building on their plans and where they want to be or their goals for year 1 and 3 years from now to see if there's one of those that they want to change. But it really is picking out what the youth wants to do. So if the youth declines, explore with them some of the reasons for choosing not to change or not to do change planning at this time. What are the pros and cons of that decision? So we're very firmly based in motivational interviewing throughout this. We also use these, the importance ruler, the readiness ruler, and the confidence ruler, to look at how important is it for them to want to start planning for the change now, to how ready are they to actually do that, and how confident are they. These are a wonderful tool for helping get some conversation going on around that change talk. One of the things that we do for the parent session, we actually talk with the youth about what and how much we can disclose from their session. So we wanted to review the reason for the meeting with the parent or the caregiver guardian, and we're really after generating empathy. We want to have that empathy in place so that they have an understanding of where the youth is at that point in time. Provide feedback on the youth sessions, and discuss the attitudes and the rules that are going to be helpful for them in communicating with their youth. And we discuss the parents' commitment to support the youth in making the change. Okay. So this is the exercise that we use for that, which is what was I like as an adolescent. So helping the parent remember back what it was like, what problematic, risky behaviors they did. You start doing the exercise and help them reflect back to where they are. The fourth session is a joint session, and our goal is to open lines of communication. And our key elements are that change persuasion exercise, and the change persuasion is actually it's a motivational interviewing exercise where you're placed in a role where you're going to tell somebody, this is what you need to do to change. And then you reverse that and you use motivational interviewing techniques to talk about change talk and what they might want to do. And you use the importance, readiness, and confidence rulers as part of that process in motivational interviewing. I want to review the personal feedback report. I want to goals and plans from the brief intervention sessions. And then we want the youth to lead that if at all possible. And a shared goal and planning exercise using that planning change worksheet again is to work with that to see what will the parent commit to, what will the parent caregiver add to that session. And our last one, and we're aware of that, is an optional discussion of effective arguing principles. Okay? So the change persuasion exercise is we ask the parent to come up with a goal for personal change or involvement. Something light. We don't want anything heavy in this one. For example, losing weight, exercising more. The youth is then instructed to very assertively persuade the parent to achieve that goal, making the strongest possible cases they can, highlighting all the negative consequences, all the things that we do when we're trying to persuade somebody. And then we debrief with the parent and see how they experienced that interaction. And then we reverse that. We go back to our motivational interviewing and some of the work that we've done with the youth. And then we debrief again. And we see where we are. We may be actually making or suggesting a referral for additional work if that's not a possibility with the folks that we have in place already. So our referral, and we can't talk about SBIRT without talking about the referral, we believe that we will be able to have at least a 15% reduction in the onset of substance use, as well as the improvement in school attachment with most of our youth. We're kind of anxious to see what the numbers are going to be, and we should and will have the ability to make the referral for ongoing assessment and or treatment as necessary. So before we get to the implementation stage, do we want to do questions, Sarah?
Sure, we have a couple questions here. Let's go up here to the first one. Okay, how is the GAIN SS modified but fidelity maintained?
Each of the individual scales within the GAIN SS is a standalone. So when we screen for substance use disorders within the GAIN, those particular 5 questions have got their own sensitivity and specificity. when we look at the internal disorders and the external disorders, which are the 3 screens that we'll be using, they also will stand by themselves. And then the total disorder score is also standing by itself as well, even though we've reduced the scale on that from the 23 questions down by 7 questions. We have the numerous discussions with Chestnut Health Systems and Mike Dennis about the nature of that and what maintains fidelity with the tool.
Okay, and the next question, could you talk about using the CRAFT screening tool and why you might not use it?
We chose to use the GAIN SS because of our recognition that with youth of this age is that we really wanted to have a robust co-occurring disorder screener. We're also using the GAIN SS because of the recency measures in the GAIN. We're able to take a look at change over time. So part of our evaluation strategy with this is to look at re-administering the GAIN short screener at 3 months after the initial sessions and then 6 months after the initial sessions. So that's what we're going to be doing for the Reclaiming Futures project, and we'll mirror that with those that are non-professional.
Sorry, Geoff, we just lost your audio there. Could you repeat the last part of your sentence?
Can we start from, we use the GAIN SS, the short screener, and we use it at the 3 months after the initial intervention, and then 6 months after the initial intervention in order to look at change over time and look at our outcomes. So the ideal and what we've been seeing with the GAIN SS in use here within King County is that if we do successive ones, then we are able to capture that information as part of the evaluation.
Okay, and I have one more question for now. What exactly were you evaluating with the GAIN, and did you use any drug screen?
We're not using any drug screen in the schools, but we are looking at that self-report as well as looking at change in behaviors. We'll also look at things such as unexcused absences and see whether that is better, but we really are looking at the particular questions in the GAIN.
Okay, and if anyone has additional questions, please feel free to submit them to the questions box, and we can do one more question and answer session at the end.
Okay, that sounds good. So where are we with implementation? Well, we've gone through the exploration stage, and we're now in that installation stage during this 3 months. And the initial implementation will actually begin really close to December, but probably not till the beginning of school in January. And then that full implementation will actually begin, depending on the school itself and where we are with the relationship within the schools, will actually begin in January and continue on through 2016, and I'm hoping into 2017. So if you haven't seen this particular diagram, I know it's complex, and I know this is almost death by PowerPoint, but it really was something that has helped me think about, what are the drivers to implementation, and especially the organizational drivers, and putting things back, where are we here in King County with implementation of this particular project. So the competency drivers, selection, training, and coaching, our clinical staff attitudes are extraordinary. We're actually, since they have relationships with the schools and the school personnel that we've met thus far, the school staff attitudes are really going to be very good. I think we'll have a very positive relationship with each of the schools. But with each school, it's a little slightly different relationship and a slightly different way of doing things, and we will adapt to that. Our staff training includes motivational interviewing. We usually do 2 days of motivational interviewing with any of the staff that are going to be working on this, so they're firmly grounded in not just the SBIRT Reclaiming Futures model that we're using, but they're also very much grounded in motivational interviewing. And we've been working to expand our motivational interviewing training and training more folks for the last several years. So most of our clinical staff have had more than just a brush with it. And then we have set up coaching meetings throughout the year. So we've got that calendared out through 2016 with at least 10 meetings during the year that we'll be able to work with our staff that are in the field, find out what's going on with them, address any problems on a monthly basis that they might be having, logistic problems, issues with any of the school personnel, some help on handling or working with parents, caregivers, any of those sorts of things along the way. Our organization drivers, we do have 3 different large systems that are coming together and looking at how do we address the needs of county, agency, and school. We want to honor the school environment and must, because we're really in their territory on this. The other thing that we're waiting on is we're waiting on the decision support data system. So that's the GAIN short screener, the modified version, and that's currently under construction with Chestnut Health Systems. So we will be web-based, secure web-based, with any of the data that we collect as well as the reports. I think that'll help streamline the system a great deal. Our leadership drivers, the funding, 1.2 million, a little over that for 2016, and we are just adaptive. Clinical inertia is not a problem for us, so our leadership drivers are really right there for us, and we've been able to rechannel some of the funding before and fine-tune it by the adoption of this particular model. So we were very fortunate in that. So our sustainment plan, and I usually say sustainment instead of sustainability because I want to see that it's actually going to be in place. So we will be looking at whether or not this is a cost-effective intervention and our cost benefits on it. We certainly are going to be looking for that core piece of positive outcomes. We are going to be doing ongoing evaluation, and we do that for the county funds as they stand now. And we do want to be sure that it is accepted and adopted. Without the acceptance, adopting it is going to be a waste of time. So we're going to be looking at some ways that we can measure that acceptance and adoption as part of the process evaluation. So here's our current funding picture for SBIRT within King County. We're not quite 3.2 million on an annual basis. We're fortunate because we do have that 1.32 million that is focused for youth in the middle schools that we're able to use, so that we do have this cadre of clinical staff that do such wonderful work. I do have about 1.8 million that is focused on adults in emergency departments, primary care clinics, community mental health centers. So our total funding for this is really, I think, significant in terms of what we're doing to blend the funding and to be more structured and our intervention in the schools with this particular SBIRT model. So our evaluation, Reclaiming Futures and the Conrad and Hilton will both be doing evaluation on those that opt into that particular project, and we will be trying to focus on those who have a truancy flag, any of you that have a truancy flag, and offering that to them, especially in our first 5 middle schools, but then in the other schools that need it, to be able to make the numbers that we want to really have a good evaluation of this particular intervention. The King County, our mental illness drug dependency, which is what the levy is called, is 1/10 of 1 cent of sales tax revenue that funds a numerous number of strategies, one of which is this particular strategy in the middle schools, and there is an evaluation that is done on that particular strategy in those schools with data that we collect already. So we do have some historical data, and our evaluation will include both outcomes and process. Lessons and barriers. Anticipate change. It's like our truancy interventionists. They changed. Nothing we could do about it. Changes in the environment, especially in the schools, you're looking at the building principal, can have a significant impact on that particular change. Schedules need to be adjusted. Other things that are going to show up, we know it's just, it's just the way it is. And ideally, have a backup plan or two. One of the reasons that I think we're moving in this direction is because that was one of my original backup plans, was to be able to rechannel this funding for this purpose. And then lastly for you, here's a few of the references that I've been gathering along the way, and I'm happy to share those. They have been very insightful and helpful. So that, I think, Sarah, concludes my remarks. Other than questions?
Sure, we have a couple questions, and I just want to remind everyone you can submit them to the questions box. And if you want to speak directly onto the webinar, feel free to use the raise your hand option, and we can unmute you. Okay, so our first question is, how has the success with SBIRT been along the socioeconomic strata?
Good question. I don't have that data off the tip of my tongue. I will have some additional data on that from our school or our youth-based SBIRT interventions. One of the things that we have seen around socioeconomic class is that in our hospital emergency department, there has tended to be a slippage to an intervention and a referral to treatment being the focus for a couple of reasons. One is because of the overt need and the lack of behavioral health services in the emergency department. We get some pushback in the primary care clinics the same way. I'm anticipating that as we move further into the schools is that we'll probably have some of that same push because we just do not have enough capacity to address all the need. And it takes some reminding that the focus of SBIRT is primarily on that moderate group of problems that are showing up with our youth or even with our adults, and that the interventions or the brief interventions will work best if we focus on that and then use our time for those who've got a high severity need to be able to motivate them to actually get some additional help, but not necessarily from our folks doing the SBIRT.
Okay, and here's the next question. Did you see any hesitancy from students to participating because you talked with their parents about the reason for them being there?
Well, the school is required to talk to the parents, so part of this is making sure that that's orchestrated. We do get a little bit of resistance, but for the most part, if we're working the motivational interviewing techniques and the spirit of motivational interviewing in our conversation with the youth, as well as using those first 6 questions, we believe that we're going to have a lot better success and less of that showing up. For those youth that we have done, we've had not a great deal of pushback on it.
Okay, great. Here's the next question. Did you look at or study some of the implementation research literature to assist you with your implementation?
I have, and the stuff on the IRETA and that link that you sent me, Sarah, was just excellent, and that's out of the North Carolina group. I've also been working with Dr. Brian Garner, who's with RTI, and we did some work around implementation and looking at implementation of SBIRT, and we were using the Proctor's taxonomy, which I found to be a useful way to be able to discuss what are the steps that are needed in order to be able to implement something effectively, and what should you be watching out for. So that's where my talk about acceptance and adoption comes in, and the cost effectiveness. These are things that are part of that particular implementation taxonomy. I just found it a useful conceptualization.
Okay. Is the GAIN SS free, or is it required to be purchased, and is training needed?
Let me go in reverse order. There is some training that's needed on that. I can usually do the training with our folks within an hour is about all that it takes. There's several options that you have with Chestnut. We're in the process of working on an implementation of the GAIN SS for all of the high school students at one of our high schools in the county at the request of the principal. And we're going to be using the GAIN SS web-based system, and they're actually going to be doing the GAIN SS on their Chromebooks that the school provides them. So we're still early in that, but we'll have some more information on that in November. But that's one of the options that you've got with that. I believe that the GAIN SS is very reasonable. It is not a per screen cost. So it's more about establishing that relationship with Chestnut Health Systems. I think the price that they gave me for the web-based, which has got unlimited users or unlimited, we have as many students as we want, as many implementers as we want with that, I think it was $500 a year.
Okay, thank you. And here's the next question. Have you observed whether or not youth whose parents were involved in the SBIRT process showed greater improvements than students whose parents were not involved?
We're still a bit early to tell on that. As we get further into our implementation, we'll have some more information. That's a great question, and it's one of those that I've been curious about as well.
Okay. Is there any opportunity for healthcare reimbursement for services, i.e. delivery of SBIRT, perhaps through school-based clinics?
The school-based clinics are eligible in Washington State. When it comes to reimbursement, either Medicaid, Medicare, or insurance, in this case it would be Medicaid with youth, then it really is a state-by-state look at where and who has to be doing the intervention and whether or not this particular intervention is best suited for a SBIRT billing or whether it's suited for a therapy billing. And again, that goes back to who's doing it. I can tell you that here in Washington State, there is a shopping list of individuals, licensed clinical social workers, MDs, ARNPs, marriage family therapists, licensed marriage family therapists that can bill Medicaid for the intervention. There's another group of individuals that can do the intervention but have got to bill to a provider, and that includes our chemical dependency professionals. And then there's also a criteria around that where is the intervention done. You know, if it's office-based, clinic-based, there are some requirements that our state has put on it. And like I said, every state's a bit different.
Okay, we've had someone raise their hand, and again, I'm going to apologize for a mispronunciation of your name, but Gwinnell O'Neill, I'm going to unmute you. Oh, we're just having a little bit of trouble getting her off mute. Gwinnell, while I'm working on the audio, I'm going to read the next question. Are there any cultural adaptations that you've made for specific groups within the population?
We've identified 4 languages at one of the schools that we'll be doing translations into. The King County is a very diverse community. I have some of my agencies have got as many as 17 to 25 different language cultural groups that they work with translations. We will be making those adaptations without a doubt available simply because that's what we do. In terms of other adaptations, we do and have looked at the GAIN SS a couple of different ways, and it may not be totally appropriate with some of the cultural groups, but it is my guess, like it has been within our present system, is that the youth has fewer problems with the language and with the cultural and understanding the culture than the parent or caregiver may.
Okay, I'm just going to give this one more shot for Gwinnell. We're just having some trouble getting her audio unmuted. Gwinnell, if you'd like to submit your question to the questions box, we can read it aloud for you. The next question we have is, do you provide AOD educational materials to the youth and or parents, and if so, what are they? Oh, Geoff, it looks like you're on mute. Geoff, can you?
Oh.
There we go. We couldn't hear you.
Okay, sorry. We don't provide any specific materials for the youth and the caregiver at this point in time, but we do use the provide elicit technique within motivational interviewing to find out, one, what it is that they already know so that we don't over-provide or just tell them things that they don't know, but then also ask permission to go ahead and give them additional information. So we have a lot available. It's just a matter of how you package it so that we're not just giving the same thing out to everybody.
Okay. We have time for just a couple more questions. Are you using fidelity and quality tools to monitor what's happening in SBI?
We are, and we're using especially the structure of the GAIN. The Reclaiming Futures version, we'll be taking a look at what fidelity tools that we're going to that will be part of our implementation. We do monitor the GAIN short screen. We haven't made any decisions about whether we're going to be doing any taping at this point. There's been nothing discussed about that. So an observation can sometimes be a difficult thing to do and can get in the way. We'll just have to see. Jury's still out on what actually we're going to be looking at in terms of the fidelity.
Okay, and then I have one last question here for you. Are there any summaries or findings reports that are available on the process or outcomes or lessons from the studies?
At this point, we're still early in the evaluation and implementation process. So a year from now, I'm sure that we'll have some good stuff for you. But at this point in time, we don't have the end for those that we've done to be able to make any judgments or any reports on it.
Okay, well, thank you, Geoff. With that, I'm going to wrap things up. That was a great presentation, and thank you to everyone for joining us today. You will be receiving a couple of emails from us following this webinar. They will include the evaluation survey we have, as well as the continuing education credit or certificate request. You'll receive one hour after this webinar, and then 2 following it. We'll also be disseminating a PDF version of the PowerPoints, as well as the recording of the webinar, which will be hosted on our IRETA website. If anyone has any additional questions, you can feel free to send them to info@ireta.org, and we will send them Jeff's way and then disseminate the answers after the fact. Geoff, if you have nothing else, we can conclude. Thank you.
Just to say thank you very much, and thank you to all that.
Oh, Geoff, you just went on mute there.
There, am I off now?
We can hear you now. You're good. All right. Well, thank you, everyone, and have a great day.